welcome everyone, and just want to reiterate, if you do have questions, please don't put them in the chat, but do put them in the Q&A section. Today we are going to talk about how the WAIS-5 is applied in healthcare settings. And we know that it's used in a variety of different venues and settings, of which private practice, kind of non-healthcare based settings, schools and academic settings and whatnot. But we are really going to hone in on how it's most actively used in that environment. The other thing that just want to highlight is that as we go through the presentation today, I'm going to do kind of a broad overview of the WAIS and some of the reasons and rationales behind the design change and some of the updates, and then we'll get into more of the specifics of its use in the healthcare setting. It's always nice to talk about what's new when we have a renormed or restandardized test. So, of course, one of the most important things that we like to do is make sure that our norms are reflective of the current demographics of the society or the culture in which it is predominantly being applied. And so, to that end, we have updated the norms of the WAIS. Also, we regularly ask the most, the active participants in the field, what are some of the most significant, I guess, pain points or pinch points when you're doing testing? And as you all are aware, administration time is always a very critical factor. And so over the years, as we've gone through each of the normative incarnations, rather, of the WAIS, is that we have consistently sought to make it as time friendly as we can, so that your time is valuable, and we want to be able to provide the kind of information that you need in a timely manner, but also make sure that it gives you that information. And so part of the test redesigns and redevelopment always has that in mind. We will also go over the new test structure. Some aspects of it are familiar, but there are new components to it that I will highlight. And along those lines, I will also mention some of the new subtests that were brought in to modify the WAIS so that the new structure is cohesive with the other WAIS products that have been published prior. I will also do kind of a quick overview of some of the special group studies. And for our purposes, when we get into the application in the healthcare setting, I'm really going to hone in on three specific subgroups that I think are most actively evaluated in that healthcare environment. And that's really just to also give you a kind of flavor of the differences of how different diagnostic groups represent or present on the WAIS, and a strategy that you can use to kind of hone in on those groups, at least as your initial start point. We also wanted to develop the WAIS so that it is meeting some of the contemporary demands of the clinical utility that we encounter in our practice environment. And to that effect, this has been a migration over really decades and getting better at teasing out some of the more nuanced aspects of how people process information. And then we also wanted to have just an overall improved user experience. And this is both for the examiner and the examinee. And I think that we have been able to create a tool that has really satisfied that goal. So as many of you are probably aware, one of the most important aspects of why we need to update norms is because of the impact of what's known as the Flynn effect. And this, in essence, is that every about decade or so, we see an elevation of IQ scores about approximately 3 points. Okay, so we see a 3-point increase in full-scale IQ every decade or so. And that alone is an important reason why we need to have updated norms. Because if we didn't, what would happen is that people who are being evaluated today on a test that may be 20 or 30 years old might have IQ scores that look like they're 3 to 6 points higher than they truly are in today's contemporary environment. So we want to be able to accommodate that and make sure that we're giving accurate, up-to-date information. As you can see, the prior WAIS was published in 2008. So we are over that 10-year goal. And as I mentioned, older tests might overestimate some of the client's scores. Now, normative data for the current WAIS was collected in 2023 and 24. And we did align that with the kind of current census and demographics in the United States so that we have accurate information that is aligned with the population changes, education changes, social economic changes, and so on. I do want to note that we actually had, even though the prior version was 2008, we had started the renorming before COVID, and we had collected approximately 30% of our data at the time when then COVID basically shut everything down, as we all know. So what ended up happening is that when we are doing normative data collection, is we don't want to draw it out over a long period of time. So we have kind of a discrete window of data collection that we can use in our analysis. And so if that window for some reason gets extended beyond that appropriate containment, I guess, such as what COVID did, is that the data that we collected early on becomes obsolete in the use of our representative, being represented in our normative sampling. So as a result, what we had to do was basically restart the normative process when COVID opened up and we could start doing testing again. And so that's the most significant reason why we have the delay of a little bit over that decade goal, is because of those factors. So one of the most happy circumstances of the new WAIS is that we have been successful at reducing the administration time down to 45 minutes in order to attain a full-scale IQ. Now, similar to the WISC, is if you give them the WISC, is that you have several options now for generating an IQ score. You can do the basic IQ using 7 subtests, but the caveat here is that even though only 7 subtests are being used in the calculation of the IQ score, we do want you to administrate the digits forward prior to the digit sequencing. The digit sequencing is loading now for the full-scale IQ with the 7 subtest approach. And the reason we want you to do that is because when we were doing our normative data collection, the digits forward was administered prior to the digit sequencing consistently. And so we want to have continuity in the data collection process for generating your IQ score using the 7 subtests. The other option is that you can generate the full-scale IQ using 10 subtests that will then also give you data to calculate the 5 primary index scores. And this we anticipate will take 59 to 60 minutes, depending on the level of abilities and so on. And as noted, this requires 10 subtests. Now you notice I did say 5 index scales. So that is one of the more significant changes with the structure of the WAIS-5. And for those of you who are familiar with the WISC-5, you will see the continuity in the 5-scale structure. Now, when we had originally, when we had renormed the prior version of the WAIS, we had really been trying to tease out the perceptual reasoning index into a visual spatial and fluid reasoning index, but it just wasn't quite there yet. And it wasn't really until the WISC came out that we were able to develop and identify the robust scales that have now become a part of the fluid reasoning and visual spatial indexes. So, it was progress over time, but now we've been able to get it caught up with the overall structure that's consistent with the Wechsler family of products. So now we have the verbal comprehension, visual spatial, fluid reasoning, working memory, and processing speed indexes. And as you can see, this is represented by the 7 subtest generation of the full-scale IQ. So for verbal comprehension, we include the similarities in vocabulary. Visual spatial is the single subtest of block design. Fluid reasoning is comprised of matrix reasoning and figure weights. And then working memory is comprised of digit sequencing. And remember, we have to then also give the digits forward condition for this. And then processing speed is comprised of coding. We only have one substitution which is permitted when deriving the full-scale IQ score with the 7 subtests. Okay. For the primary indexes, the verbal comprehension is comprised of similarities and vocabulary, visual spatial block design, and we added visual puzzles. Then fluid reasoning is comprised of matrix reasoning and figure weights. Working memory is digit sequencing, and then the new running digits. And then processing speed is comprised of coding and symbol search. Please note that subtest substitution is not permitted for any of the primary index scores. So let's talk about some of these primary index scores because they're new to the WAIS-5. It's helpful to think of the visual spatial index as the analogy is like that of an architect, where we are able to use visual information to build a complex geometric design to match a model. And this is what we are really tapping into when we are using block designs and design and visual puzzles. Whereas the fluid reasoning, the new fluid reasoning index, the analogy is that of a detective, where we are able to use that visual information that's presented to us to identify the common theme or concepts that are comprised by these prompts. And we use matrix reasoning and figure weights to assist in that. So one of the most exciting aspects of the WAIS-5, at least for me, is the addition of a number of new ancillary index scales. And this is really, I think, where the rubber hits the road, where things get exciting in what the WAIS-5 offers us. So going from left to right, you can see that we have added what we call a verbal expanded crystallized index scale. And this is going to be comprised of those core kind of tried and true crystallized intelligence subtests of similarities, vocabulary, information, and comprehension, which kind of build on the level of complexity as you get each of these subtests. Then there's the new verbal reasoning ancillary index scale, which is comprised of similarities, comprehension, and then the new set relations. And for these, what makes the difference is that they're really honing in on the higher order reasoning skills that we have to use in order to kind of understand the relationships between these higher order concepts that are verbal in nature. Then we have the new expanded visual spatial index, which is comprised of block design, visual puzzles, symbol span, and then spatial addition. In addition to the fluid reasoning, we have also added the expanded fluid reasoning index, which is comprised of matrix reasoning, figure weights, arithmetic, and then set relations. And then the quantitative reasoning index is comprised of figure weights and arithmetic. And it's helpful to think of figure weights as almost like an analogy to algebra calculations, and yet you don't have to do the mathematics. So it's really tapping into that quantitative reasoning component functioning. And then we've also added so the working memory indexes, ancillary indexes are contributing quite a bit in understanding some of the more subtle process of working memory. And to do that, we've included the expanded working memory index, which is comprised of digit sequencing, running digits backwards, letter number sequencing, symbol span, and spatial addition. And you may be familiar with the symbol span and spatial addition, which is in several of the indexes, as they were formerly in the WAIS-4 and now are included in the WAIS-5. The visual working memory index, which is comprised of symbol span and spatial addition, and then the new auditory working memory index registration. So this is comprised of digits forward and then running digits. And to give a description of running digits, I know I've been mentioning that a bit. This new working memory subtest is comprised of reading a series of numeric digits to the examinee that are delivered at 2 digits per second. And as the strings get longer and longer, what we ask them to do at the end of that string of digits is to remember the last 4 or the last 5, the last 2, kind of depending on where they are. So they don't know when you're going to stop. So they really have to be attending and registering as best they can. And then when you're done, you ask them to basically tell you what the last 4 were. So it's pretty challenging. it's a really very sensitive tool to working memory registration. And then there's the auditory working memory manipulation, and this requires some higher order skills, which is comprised by the digit sequencing, digit backward, letter number sequencing, and it really requires set shifting in how they are managing that working memory focus. So then there's a new expanded processing speed, which is comprised of coding, symbol search, and then naming speed quantity, which is also a new subtest. Okay, which has nice thing about the naming speed quantity is it doesn't have motor demands in the way that coding and symbol search do. So you're getting a more comprehensive look at that processing speed component. Then there's the the motor reduced processing speed subtest, which is comprised of symbol search and naming speed quantity. While symbol search does have a motor demand to it, it is less complex as the coding, as you all know. And so it gives us a bit of a step down from the task demands that we see with the coding. So that's why it's in here. And then there's also the non-motor index, which is comprised of similarities, vocabulary, visual puzzles, matrix reasoning, figure weights, digit sequencing, and naming speed quantity. And then finally, in the last columns, we have the general abilities index, which is nice to have because it pulls out some of the impacts that can lower an IQ score based on working memory or processing speed problems. And this is helpful for folks who may have some maybe impairments that are related to motor functioning insults or palsy or whatnot, so that you can get a good general idea of their abilities without the bias of the working memory and motor skills reducing those scores. And then also the cognitive proficiency index, which is comprised of digit sequencing, running digits, coding, and symbol search. And then finally the nonverbal index, comprised of block design, visual puzzles, matrix reasoning, figure weights, symbol span, and coding. One of the nice things about now the WAIS that was not in the prior version is that with the new non-motor index is that you can actually do remote testing and get scores that you can then you can either compare to an IQ score if you have that, if you're not doing remote testing. But if you are doing remote testing, you can get a non-motor score that is highly correlated with the IQ score. And this is very helpful, particularly like in VA settings where you have clinics that are far away from the general environment of VA and where they may not have psychologists readily accessible for testing. So in order to make some of these changes, we had to say goodbye to a few for the familiar subtests of the past. So first is picture completion. And we removed that because the construct that it supported was not as representative of the visual spatial abilities as some of the others that we have added to the subtest, to the test. Also, there was a decreased emphasis on speed with that, and so it would make the test take longer. And frankly, it was just not frequently used. And this is from the feedback that we got from the community. Cancellation we also removed because it had overall very low G loading, so it wasn't really tightly wrapped into the concept of the full scale IQ as well as some of the other subtests. It had relatively low correlation with other processing speed tasks. It was not very clinically sensitive in adults, and there are other measures of visual neglect that are available for adults that are much more sensitive and going to hone in on those areas of concern than this one would tap into. And also there was a desire for motor-free processing speed measures, which we added. What we also brought in was the new set relations, which is part of the fluid reasoning index, and this is what I described earlier. Running digits is what I described earlier. Set relations, what this does is this provides a series of visual cues that have various types of relationship potential to each other, and we have to ask the examinee to select the relationships between these items that best describes how they are related. And there's multiple options. There's going to be 4 options, and then for the more difficult tasks, it allows for 2 points and 1 point responses. And then running digits I mentioned. Then there's a new naming speed quantity, and this is in essence we are presenting the examinees a series of boxes with boxes inside the boxes, or dots inside the boxes, and they are supposed to articulate how many dots are in each of the boxes as they go across as fast as they can. So similar to coding, where we have them write the symbols from left to right as fast as they can, with naming speed quantity, we're just quite simply having them articulate the number of dots in each box as fast as they can. And then there the symbol span that was imported from the WIMS. And this is it's a visual memory subtest. And then spatial addition, which is also imported from the WIMS. So why do we want these types of subtests in healthcare settings? Why would we want these? So particularly with set relations, for example, is that we are really trying to tap in some higher order reasoning abilities that that may be impacted by head trauma and whatnot. Also, it can offer a decent comparison for folks who maybe are maybe highly intelligent and maybe maintain some of their upper or higher order reasoning skills, but then begin to see impairment some of their more fundamental skills like working memory and processing speed because of insults. The same with running digits. It taps into registration, and so if you have impairments that are going to impact registration, this will be very sensitive to that. Naming speed quantity gives us the capacity to assess processing speed in a way that does not have motor demands. And so if there are insults that have caused some motor impairment, we can get some good data about the core processing speed ability without some of the motor bias impacting it. And then symbol span is a good visual processing task, visual memory processing task. That's sensitive to insults and to the visual processing field. And then again, spatial addition is similar to that, which also involves both visual processing, but then also some calculation skills as well, which can become impaired based on a number of insults or decline in function. So whenever we do renorming, we will always like to basically see how the test works. Is it sensitive to identifying differences in groups compared to normative or match compared samples? So we did a series of group studies. One was the first one hit on real quick is the intellectually gifted group. While this may not be necessarily tested in the healthcare environment, one of the nice aspects of this of the WAIS is that if you are testing gifted folks, is that we have recommended start points that are more advanced items, so that you don't have to spend as much time giving a full test. Because as many of you know, when you're testing highly intelligent people, if you start at the traditional beginning start points, it ends up adding a lot of time to the overall test because they go further. So this allows you to expedite some of the testing for the gifted folks. And then we looked at intellectual disability, both mild and moderate conditions, and we found differences between each of these categories in match controls, as well as levels of severity. Specific learning disorders in reading and math, attention, we had looked at attention deficit hyperactivity conditions, as well as autism spectrum, and then TBI, both moderate and severe, and then mild cognitive impairment, which can often be precursor to Alzheimer's or other early onset dementias, or maybe the result of concussion or some TBI or other traumas. And then probable dementia of the Alzheimer's type, moderate severity. So the other desire was to expand clinical utility in the healthcare environments across the board, but also as it has relevance in the healthcare environment. And so we had broader construct coverage for working memory, fluid reasoning, and processing speed, predominantly with the ancillary scales, as you saw. And then also new expanded index scores for increased interpretive clarity, as I showed. And then new index scales that reduce the confounds of expressive language or motor problems. And also there is the capacity to do remote testing now in a way that we hadn't been able to do with a high level of reliability before. And these are done through the nonverbal index, the non-motor index, and the reduced motor processing speed index. So you can tease out some of those biases that might influence the scores. We also really targeted improved user experience by simplifying administration and scoring directions, and then also multiple options for administration, scoring, and reporting. So of course, there's traditional paper and pencil kits that are available, and these can be scored both by hand as well as using Q Global. And then there's also the Q Interactive, which requires 2 iPads. No record forms are required. You do need response booklets for the test, for processing speed, but that's it. And then blocks. And then the Q Interactive includes both administration directions as well as real-time scoring and then reporting. And I'd like to let everybody know that this was released on September 19th. So if you do have Q Interactive, you will see the WAIS-5 is now available on that system. And if you use the WAIS-5 on Q Interactive and you do want us to send the protocol for the processing speed or blocks, you just need to contact customer service to have those sent to you if you don't already have those resources. All right, so let's really hone in now on how the WAIS-5 is typically used in a healthcare setting, okay? Because it is different in how it's applied, and partly this is largely due because of the nature of the clinical questions that are being asked. But typically, most of the testing, or often testing, is done by neuropsychologists who are the primary evaluators in the healthcare environment, or evaluations by clinical psychologists who do have significant neuropsychology focus or have that support available. But it tends to be much more geared towards that neuropsychological kind of drill down. And typically, testing in healthcare facilities don't really need the full-scale IQ. They often don't ask for a full-scale IQ. They're used more actively in trying to assess kind of functional impairments based on the problems that are being presented within those healthcare environments. And so often, subtests might be used more specifically, or specific indexes without the requirement for the full-scale IQ. When an IQ is generated, it's usually done so that they can get an overall estimate of functioning. So the practice focus in healthcare settings is to look at more usable data by using a subtest and index focus, and then use subtest combinations that would answer questions. So overall, it's said that it's kind of helpful to understand that when you get an IQ score, you're really looking at how somebody thinks based on the parameters that we are identified to tap into how they process information along some of those domains that we've talked about. In the neuropsychological approach and in the healthcare approach, we're really looking at what's functionally not working. So versus how do you think? So IQ is how do you think? The neurocognitive approach is what's not working. Okay, and this is what we do in the healthcare environment. Also, it's often used to assess readiness or capacity to return to work after traumatic brain injury or stroke, or tumor, or anoxic injury, or meningitis, or some kind of insult. Okay, it's used quite frequently for this. And as one of my colleagues noted, is one of the biggest challenges is when you have highly intelligent, highly functional people, because you really want to know where they were functioning. Okay, so classic injury, for example, is for doctors is a TBI from cycling injuries. I guess they see this a lot, a lot more than I realized. That lots of mild TBIs have symptoms that can affect efficiencies, particularly kind of the working memory efficiencies, the processing speed efficiencies, and that concussions drop these efficiencies significantly. And so some of the new supplemental subtests really allow you to tease apart some of those impacts, such as working memory registration versus manipulation. And what you would really see is more of the manipulation impacts versus maybe the early registration. And then maybe some higher order reasoning struggles as well, kind of depending on the nature of those insults. So a typical strategy in the healthcare setting is to interpret scores individually and observationally, so that people with cognitive problems might have more spotty responses in their profiles. You see more variance, which extends the time to take the test and or the subtest as well. So, if you're giving the full test and doing all the subtests, it would become more lengthy. So often there's an important rationale to really kind of hone in on what those areas of impact are, unlike you might do in the kind of general private practice setting. And this was an interesting comment also from one of our colleagues, is that in the healthcare environment, and he said not using Q Interactive could be a liability based on scoring challenges for some of these folks. What he's basically saying is that it's good to use Q Interactive because it's built intuitively into the testing environment for you. So I just want to share that with folks. So what's a good strategy to use, kind of our clinical approach in the healthcare environment? So first is you want to consider specific subtests or indexes that are going to provide the information that's going to be relevant to assessing the type of functional impairment you're concerned about, or the functional impairment they may be caused by whatever that neurological insult or deterioration may be that's presenting to you clinically. You use the full-scale IQ to estimate general functioning, okay, but expect more usable information from the subtests and then indexes. Because as I noticed, we're looking at really what's not working, okay? But sometimes it's good to have that IQ as well, particularly if you're trying to kind of get an estimate of that pre-morbid functioning. And if you're familiar with the WAIS-4 and the LIMS-4 in the ACS, those combined will really allow that process to happen. The ACS system will be available after the WIMS is published and then the ACS is completed. So the WIMS will be, I think, about 6 months, and then the ACS will be available the following summer after that, so about a year and a half. So the next thing you want to do is observe for variable or spotty performance on the WAIS-5 across subtests, which can provide insights into functional impairments caused by that neurological insult. So remember, before I said, when we were looking at the indexes, this is really where the rubber hits the road. This is where the things that's where all the action is. And so I think that's, this is in that same spirit. You're really looking for the specific aspects of impairment, not necessarily looking at the full-scale IQ. And then provide adequate time to evaluate the examinees, as it typically it might take a little bit longer because of the impairments that they have that impact functioning. So while our standardization said, testing will be 45 minutes or 60 minutes, depending on what you do, when you have those functional impairments, it might add a little bit of time, which is one of the differences you may see in a healthcare environment versus the private practice setting. All right, so I'm going to walk through three examples of typical medical presentations in the healthcare environment, and which subtests or which indices you really want to hone in on to help identify the differences in processing. And each of these conditions, I think you'll know, they get richer and richer as far as what you're going to be tapping into. So we're going to look at TBI, traumatic brain injury, mild. We'll look at mild cognitive impairment, and then probable dementia of the Alzheimer's type. So with traumatic brain injury, anticipate WAIS-5 testing profiles that have, that within our own sampling, that have large effect sizes, okay? So first, you're going to anticipate lower scores by approximately 1 standard deviation on the overall full-scale IQ, okay? Also with TBI, we would anticipate lower scores by approximately 1 standard deviation on multiple indexes, of which I have listed below. Okay, and again, we saw large effect sizes when we used that stood out with these indexes compared to match control. Okay, so the extended working memory index, we're going to anticipate lower scores on that. The motor reduced processing speed index, the auditory working memory index, manipulation. Okay, not registration, but manipulation. The expanded processing speed index, the cognitive proficiency index, and the working memory index. Okay. But depending on the type, location, and severity of the TBI, anticipate lower scores on all these. I just basically said this, so that's a duplicate slide. Okay. All right. When we look at the indexes in the subtest, so with lower scores on the working memory index, which is comprised of the subtest digit sequencing and running digits, the differences between our match controls had large effect sizes, so it's very sensitive. Okay? The expanded working memory index saw large effect sizes on the digit sequencing, as noted, and then the running digits also had large effect sizes, noted. But then also we saw differences in digits backwards, letter number sequencing, symbol span, and then spatial addition. Okay. So we're seeing this in both the auditory as well as the visual working memory because it's combined. Okay. Then on the motor reduced processing speed index, remember we pulled out coding for this. We saw differences on symbol search and naming speed quantity, which had a large effect size. And then on the auditory working memory index manipulation, we saw differences on digit sequencing, which had that large effect size, digits backwards, and then number letter sequencing. Okay. Again, these are all auditory. On the expanded processing speed index, you can anticipate lower scores on coding, symbol search, and naming speed quantity. And remember, we call it expanded because we're also adding in a little bit more of the motor demand that is included with coding. Okay. And then the cognitive proficiency index, which is comprised of digit sequencing, running digits, coding, and symbol search, with the large effect sizes on the top two, digit sequencing and running digits. So you can anticipate with the TBI that you may want to hone in on the subtests and scales that will give you that data. You would anticipate differences. And that, again, I was reviewing mild TBI conditions. You would just anticipate larger effect sizes or larger differences in scale scores compared to match controls for moderate TBI experiences. Now, pivoting over to mild cognitive impairment, we would anticipate lower scores on full-scale IQ, processing speed index, expanded working memory index, visual working memory index, auditory working memory index, the manipulation, nonverbal index, non-motor, the GAI or general ability, and then the cognitive proficiency index. So as we tease these apart, the full-scale IQ, 10 scale assessment strategy, you want to hone in on all of the kind of primary indexes, okay? Because they will stand out as different from the match controls. Then with the processing speed index, we can be comprised of lower scores in coding and symbol search. The expanded working memory index, you can anticipate lower scores on all the subtests that load on there as well, the digit sequencing, running digits, digit backwards, letter number sequencing, symbol span, and spatial addition. On the visual working memory index, we will see lower scores on symbol span and spatial addition. On the auditory working memory index manipulation, you see lower scores of digit sequencing, digit backwards, letter number sequencing. And then on the nonverbal index, we would anticipate lower scores on block design, visual puzzles, matrix reasoning, figure weights, symbol span, and coding. And then for the non-motor index, we anticipate, and we saw lower scores on similarities, vocabulary, visual puzzles, matrix reasoning, figure weights, digit sequencing, and naming speed quantity. Okay. The general abilities index for the mild cognitive impairment, we saw lower scores across similarities, vocabulary, block design, matrix reasoning, and figure weights. And then in the cognitive proficiency index, we saw lower scores in digit sequencing, running digits, coding, and symbol search. So as part of your initial strategy in assessing for mild cognitive impairment, as you can see, compared to the TBI group, there's more subtests involved that showed sensitivity to differences in match controls, okay? So now, kind of raising the bar to the more severely impaired folks that we suspect have Alzheimer's of the presentation of the dementia of the Alzheimer's type, we would anticipate lower scores of over a standard deviation on all of the primary index scores. Now, when I was going over that mild cognitive impairment, there were a lot of indexes that were in there and subtests, but they weren't as consistently globally represented with deficits as you would see now in the suspected Alzheimer's group. Okay, and the effect size and the differences were all significantly different. Okay, but the lowest of which was the working memory index, which had a moderate effect size of 0.7. Okay, but the rest of them were all large, all the other indexes. So we would anticipate lower scores of over one standard deviation on all the primary index, with the exception of auditory working memory registration. And this is what we saw in our own analysis of comparison groups. And you can imagine that the task demand in auditory working memory registration is immediate, whereas when you have to start to lean on the the working memory components to it, the kind of moderating, like not moderating, but the manipulation of the data that you're getting with the working memory task demands, is as soon as you start doing set shifts, kind of cognitive set shifts, and having to hold multiple pieces of information in real time and then manipulate them and get the correct answer, that's where you really see the decline. Whereas immediate registration, you can do that pretty quick, and the early onset Alzheimer's group, or probable Alzheimer's groups, tend to demonstrate that as well. And then just give you a visual sample of what kind of the differences were on our own comparison group studies. And as you can see, the auditory working memory compared to matched controls, the mean was 95, matched controls was 97. But you see consistent global decline across all of the indices in the probable dementia of the Alzheimer's type. All right, so it has been my goal to give you kind of an overview of what the redesign of the WAIS-5 was, and familiarize you with the new structure of the WAIS and describe its relevance and use in the healthcare environment. And I hope that the samples of examples that I gave you kind of give you a flavor for some of the differences in the depth of kind of how far you drill down and get under the hood to understand what's really not functioning well. Also, to identify which indexes might be most useful among the patients that you support in a healthcare environment, so that you can be targeted and selective in your approach. Maybe not giving the full test right away, but really honing in on some of the subtest components that give you the information that we need. And also, because time may be a factor, and where it may become a longer testing scenario because of impairments, that doing kind of the full battery approach of the WAIS may not be ideal in those healthcare environments. And also, I wanted to kind of give you a sampling of a demonstration of how to utilize that information that's provided by the subtests and indexes to really give you information and help articulate some of the impacts that the clinical presentations are creating in these individuals' lives, and that are very common in healthcare settings. Now, while I only covered 3, there are many more, but those are the typical ones. Some hospital and settings do more autism testing, for example. I didn't cover that in my examples today, but we also saw significant differences in the autistic autism group, mild autism group, compared to matched controls. And then I didn't give examples of the ADD or ADHD. But what we do find is that when we looked at the ADD, ADHD to match controls, that there wasn't a significant difference. So what that suggests to us is that you want to use probably other tools to really help identify other executive functioning tools or behavioral assessment measures to better articulate some of the issues with ADD, ADHD. We often do see working memory and processing speed issues with people who have ADD, ADHD. But you can't always say that's the smoking gun of that diagnosis. So while I didn't give you the data on that and kind of the strategy, just know that those comparison groups are available in the technical manual, manual basically, and the normative tables that are available in the manual. So questions, we've got about 15 minutes.
Yeah, thank you so much, Pat. We do have a lot of questions. As a reminder to everyone, go ahead and put additional questions in the Q&A chat box, the Q&A box. If you'll see 2 little chat bubbles next to each other, you can put your questions in there. Just as a tip, please do not include acronyms. We want to make sure that we get your questions answered accurately. So just little tip there as you're putting questions into the Q&A session. I'm going to go through a few questions that have come in more frequently than others to make sure that we address them for the larger group. Got a couple of questions of why the two subtests from WIMS were moved over to the WAIS-5. Can you talk about that some more?
Sure. So, I mentioned that we were trying to create a broader coverage of the constructs, and those particular subtests really do well in supporting the visual, basically the visual processing construct, the visual working memory construct that we were trying to build. So, so in all fairness, instead of having you buy another test to supplement that, I mean, we think the WIMS is a great test, but I think this also helped kind of complete that whole the breadth of what we're tapping into. So the WAIS is the WAIS-5 is a much broader, I think now, in how it gives you relevant information in these multiple fields of information processing that we're tapping into. Whereas before we kind of had, some gaps. Like I said, we were trying to get the fluid reasoning, for example, and then the perceptual reasoning or the visual processing from the perceptual reasoning, is that we weren't quite ready to tease those apart. And so now, almost a decade and a half later, we are in a much better position to really understand the nuances of those constructs. And so instead of recreating the wheel, we went ahead and used what we had already designed that was very sensitive to that. And so if down the line, when you do give the WIMS, you won't have to re-give these subtests. Okay, so that's kind of a nice boon too for that.
Great, thank you so much. We've had a lot of questions about how you would use the WAIS-5 in comprehensive evaluations for things like autism or ADHD, or even after a traumatic brain injury, different things like that. Maybe we could talk about that at a high level, how you make sure you're selecting the right subtest to administer, or any general guidance on what you would recommend to people that are unsure of what subtest to administer.
Yeah, so I hope that some of the strategy that I went over, I mean, that would be the start point. So, and what I'm using to reference that strategy, it has been both conversations with people in the field who do this all the time, as well as our own exploratory confirmative study, confirmative research around its sensitivity to those subgroups that I reviewed. So because you're really looking at functional impairment, remember one of the things I mentioned is that you're also doing observation. So when they're coming into you in a healthcare environment, you don't necessarily just want to slap the whole WAIS on them or any kind of test on them. You really want to observe through clinical interview, collateral sources about the functional impairments that are being manifested in that person's behavior. And that becomes the guide for where you want to drill into. So, if, let's say they've had a TBI, a mild concussion, okay? And they may or may not be aware of some of the behavioral impediments that are manifesting, but their spouse might, right? Or their family members might. And so, some of that observational data really then needs to be followed up and combined with the targeted subtests, or even indices that are going to give you good information around that. So let me use the doctors, for example, who have concussions, who ride their bikes. So these are individuals who operate at a very high level. Okay, and they have to be able to have obviously great crystallized intelligence, right, which we all know they probably do, but they have to have high levels of reasoning, and they got to have high levels of working memory. And they, depending on the environment that they're in, they have to be able to think kind of fast on their feet at times, right? And so those are the things that you often see impaired by a concussion, right? You have working memory problems, you have processing speed problems, but their level of intellectual acuity is so high that they can often cover quite well. So I would following kind of the interview and observations and then collateral information, if you have that available, is then I would select how I want to hone in on specific subtests that would kind of tease out things that they might be able to hide pretty well, but they can't really hide well from the test like this. Okay, so that's one of the strategies I would use. If you're looking at for example, older adults, and this will be kind of available when the ACS comes out, and you really want to get an idea of premorbid functioning, uh, then I would be inclined to give the full scale IQ, particularly if you're looking at something that might be post stroke, for example, or if you're concerned about even possible malingering of cognitive impairment. Then it would be better to give the full scale IQ because it gives you a good estimate, and then combine that with the advanced clinical solutions that was available in the prior version that will be available in this later on. So as far as the ADD, ADHD goes, now, correlation is not causation. So people will often say, well, working memory is kind of critical to ADD, ADHD. Well, yeah, it is, but it doesn't always get picked up on in the same way from this particular test that it might on other more targeted executive functioning processing measures, which really get a little bit deeper under the hood in the executive processing challenges. And then and take a multimodal approach, for example, to doing working memory testing. So, for our purposes, our working memory subtests, they are distinct, whether they're looking at auditory working memory or maybe some visual working memory or visual processing or auditory processing. So you can say, yeah, it's there, but it might not necessarily capture it. Often what you see is when you do cross modality evaluation. So let's say you have an auditory task and you also administer an embedded visual task at the same time, and they have to do set shifting. Set shifting is basically you're following different sets of rules in response to stimuli, and you have to be able to be nimble and kind of flexible. That's when you really begin to see some of the things kind of deteriorate with the ADD, ADHD issues. So in our own sampling, after we completed the development of the WAIS, we did kind of clinical examination of its sensitivity to detecting ADD, ADHD in pre-existing diagnostics, those who already had that condition diagnosed. And we saw no significant effects between matched controls. So, like I said, correlation, not causation. So I would use other measures to really pull into that if you think that's there. I hope I answered that question.
Yeah, that's great. Any guidance on test retest when using the WAIS-5 in a healthcare setting? They asked about specifically for inpatient and outpatient, and if these subtests could be used for tracking cognitive recovery trajectory.
Well, I think you can, particularly when you're doing the more real-time tests, like the working memory and the processing speed ones. I think those are they are less inclined to have some of the carryover practice effects because of the task demand, the time demands, and versus the more traditional crystallized intelligence, where they tend to they might recognize and respond to things, that may respond wrong for the last time they did it. But the manual does not articulate specifically a test retest window. I think clinically, the general rule of thumb is that it's if you're looking at doing kind of the full scale, it's probably good to wait about 6 months. It's a guideline. It's not written in stone. But I think that if you're doing progress monitoring in response to care, you probably can do some of the re-administration time over time in a more recent or a shorter window. It kind of depends on the degree of impairment, So if someone they're not showing a lot of impairment and you do test retest, you're probably not going to get a lot of qualitatively rich information. But if someone is significantly impaired or moderately impaired, and then you're wanting to kind of see how the rebounding time over time, then I think that it would be okay to do it within a shorter window, whether it's a month or 2 months or whatever. But I would not be doing it 1 week and then the next week. That would be far too soon. So I know it's kind of a waffly response, but it's not written in stone as to the exact window of test retest, partly because the task demands with each of the subtests are different.
Yeah,
So if you're doing a more iterative approach where you're doing individual subtests, I think you might have a little more flexibility and having a shorter window depending on what you're looking at.
great. We did get a question about coupons or discounts available. We do currently have a 10% discount on complete kits, and that is currently the price on our website. That price will be available until September 30th, so just until Monday, I think that is. So definitely check that out. That's going to be the lowest price that you'll be able to get on WAIS-5. And that's available, current prices reflecting that 10% off on complete kits only. Another question, Pat, I know we've got about 4 minutes left. How representative was the new normative sample? Are the norms sufficient for various cultural and ethnic groups? Are they gender diverse? Can you talk a little bit to that?
Yeah, so we fashioned the normative collection on the most recent census. So we accounted for demographic shifts, racial shifts, as I mentioned, economic variances that are regional variances and so on. So it's aligned with the last census to the degree to the degree of specificity within each kind of subcomponent of what we looked at, whether it's social, economic, or whatever. It's all going to be aligned with the census. So we have to make it broad enough so it represents the general cultural presentation of the United States.
Yeah, that's great. Yeah, I can add a little bit to that. We did have 2020 individuals in the normative sample, and depending on the age band, a different number of examinees per age band, but somewhere between 100 to 180 examinees per age band. The educational level ranged from no high school through a bachelor's or graduate degree. Ethnic backgrounds included African American, Asian, Hispanic, white, and other ethnicities, including non-Hispanic, multiracial. And then equal numbers of male and female examinees were used in all age bands, except for the 5 oldest age groups, which is ages 65 to 90, 11, which included more women than men. So just add a little bit of extra data for those of you that taken notes out there today. Well, we just have like 2 minutes left. Pat, there was another question I was going to just throw in here where someone had asked about a free year of Q Global, and I'll go ahead and answer that one too, because I think I talked about it in the last webinar. So yes, one of the options on our website, whether you get just the kit with the box or with the free 1-year subscription, you can do it with the bag or just in the box. And those are available on our website. And yes, the price on the website reflects that 10% discount. So as you look at the kit prices that are on the website today, those will be eliminated on September 30th. Hopefully that clears things up for people that were setting in kind of follow-up questions for that. There is not a code that is needed in order to get that discount. All right. Well, with that, it looks like we are out of time. Thank you so much, Pat, for sharing all this information with us today. Thank you to all of our attendees for joining our webinar today and for asking such great questions. If there is a question that we didn't get to, we'll definitely try to get back to you. But if you get the survey after completing the webinar, it'd be great if you could fill that out. Thank you again for attending today. We're so glad to have you all here learning about the WAIS-5. Thanks again. Bye-bye.
Thank you for coming.